Welcome to EPG Pathshala. We are discussing today the course on social policy. The specific module under discussion is nutrition and school feeding programs in the context of India. My name is Sohini Sengupta and I am a faculty in the School of Social Work at the Tata Institute of Social Sciences, Mumbai. Undernutrition of children is a hidden phenomenon that diminishes the strength and capacities of communities and nations by not allowing individuals to attain their full potential. Close to a quarter of the world's undernourished children live in India. The three key indicators that are commonly used for measuring undernutrition in children, and we will be discussing this in some detail in this module, is stunting, wasting, and underweight. The National Family Health Survey, which we discussed a bit in the module on health policy, shows some improvement in child nutrition data in the last decade. However, 37% children under age of 5 continue to remain stunted in India. High levels of child undernutrition indicate either societal inequalities or a great deal of poverty and diminishing food security situation in the country. The objectives of this module. In this module, the student will learn about two key interventions by the government in maternal and child nutrition in the context of India. One is the Integrated Child Development Scheme, or the ICDS, and the other is the school feeding program called the midday meal. The specific objectives of the module are to understand the need for nutrition intervention, specific provisions under the ICDS, goals of the midday meal program, and the problems and remedies in these programs which can be solved for future. Nutrition interventions are designed to target girls, women, and children at critical stages of their lives. For children, adequate nutrition during the first 2 years of their lives is viewed as critical to their future growth and development. Girls are particularly vulnerable during adolescence. Low BMI and anemia, persistently found in adolescent girls in India, can be addressed through nutrition education and intervention. Pregnant and lactating women are the third important category whose overall health and nutritional status determines the survival and the health of the unborn child. If you remember what we learned in the module on food security, the third dimension of food security or food insecurity is utilization. And nutrition interventions are especially meant to look at this dimension of food insecurity, whether children and women and people in the vulnerable age group and gender categories are able to fully utilize the food that they are perhaps being able to secure. State of child nutrition in India. In the last 3 decades, child undernutrition has steadily declined in India between 1975 to 79 and 2004 to 5, severe undernourishment has declined by 50%. Also during this period, clinical signs of nutritional deficiencies such as diseases such as marasma and edema also declined. Overall levels of child undernutrition still remains very high in absolute terms and relative to other countries. India has the largest proportion of undernourished children in the world, which is less only compared to Nepal and Bangladesh. Approximately 60 million children in India are underweight, which is twice the number of children in sub-Saharan Africa. Child mortality rates in India was 63 in 2010, which essentially meant that 63 children died before their 5th birthday. This translates into very large number of child deaths in 2010. And which accounted for almost 22%, close to a quarter of child deaths in the world takes place in our country. When we look at the different rounds of the National Family Health Survey, let's look at the last big one, the National Family Health Survey 3, and compare it with the findings of National Family Health Survey 4. And the focus of both these health surveys is essentially maternal and child health. Data from NFHS 3 revealed a worsening nutritional situation for children in India, and which led to alarm bells ringing amongst policymakers and observers. Among children in the age group of 6 to 35 months, percentage who were anemic was 79.2% in 2005-06 compared to 74.2% in 98-99. Percentage of children who were underweight was 45.9% in 2005-2006 as compared to 47% in 98-99. 80% of malnourished children in India were found in the states of Bihar, MP, Rajasthan, UP, Maharashtra and Odisha. The issue therefore was to try and understand what happened between the two rounds of the family health survey for child nutrition standards to decline, because this was also the period when India was doing very well as far as economic growth was concerned. When we look at NFHS 4 data, which is National Family Health Survey 4, the data of child nutrition and maternal health shows slight improvement. The NFHS 4 data for 15 states, which is available at the moment, shows that 37% of children under the age of 5 is stunted. This is a fall of 5 percentage points in a decade. Bihar and Madhya Pradesh are the worst off, with 48 and 42% respectively of children who are stunted. The proportion of underweight children has reduced equally slowly from 39% to 34%, with Bihar and Madhya Pradesh being the worst off again. Improvement in the area of child wasting, low weight for height. The states for which data is available have more than halved their proportion of wasted children in the last decade, from 48% to 22%. This is a very welcome news. This essentially shows that some of the nutritional intervention of Government of India, and as well as the other means in which families are improving their food security situations, are being directly translated into children attaining better health. The proportion of adult men and women with below normal body mass index have also declined. Keeping these empirical facts aside, let us try and understand how nutrition is understood and how nutrition is monitored in the context of our country. Indicators for monitoring nutrition all over the world is based on anthropometric indicators of age, height, and weight. 3 standard indicators are as follows. Height for age. Low scores indicate stunting. Weight for age. Low scores indicate wasting, and height for weight. Low scores indicate underweight. Nutritional indicators definition. Stunting is considered to be a cumulative indicator of nutritional deprivation from birth or conception onwards, which is why large prevalence of stunting among children in India is an indication of not just poor nutritional and health of the children, but something that starts with poor nutritional and health status of adolescent girls and young mothers. Wasting is an indicator of short-term nutritional status. Underweight is a more comprehensive indicator that captures both stunting and wasting. Stunting or wasting in childhood is associated with ill health, diminished learning abilities, and higher mortality. Populations with large proportions of people who are stunted or underweight show the evidence of long-term or endemic nutritional deprivation. Universal anthropometric standards, keeping a well-nourished population as a benchmark, is used for fixing the cutoff or standard against which nutritional attainments of population groups in different countries are measured. Nutrition information for India. In case of India, we have 2 sources of learning about the health status of children. The National Nutrition Monitoring Board in Hyderabad produces a state-wise weight for age data from the 1970s. The NNMB survey covers 20 households per village in 120 villages. It is operational, however, only in 9 states. The National Family Health Survey, of which 4 rounds have been conducted till date and completed, and for which data is available for most states, is the other source of health and nutrition data for children and mothers in the country. What are the causes of undernutrition? Unless we understand the causes of undernutrition, we will not be able to assess the manner in which social programs are functioning in the country. The immediate causes of undernutrition include inadequate dietary intake or childhood infection. The Integrated Child Development Scheme, which we shall discuss shortly, is aimed to take care of these causes. Structural and underlying causes of undernutrition is the other reason for prevalence of malnourishment amongst child population. The ICDS alone is not able to address structural causes of undernutrition. Some observers and monitors highlight the improvement in other determinants of child nutrition, namely maternal health, education, and safe drinking water in the last 3 decades are also essential complements to the provisioning of nutrition and health supplements through government social programs. Ineffective nutrition interventions. Are the nutrition interventions that we are pursuing at the moment effective or ineffective? Based on the National Family Health Survey findings, the conclusion that is often drawn is that nutritional programs that are implemented by the state has limited impact. Disparities in nutritional gains between rural and urban areas and between highest and lowest wealth quintiles continue to persist, which essentially means that nutritional achievements are frequently being cornered by better off sections of the population, while the gains are not as widespread or as equitably distributed as we would like it to be. Evidence of gender discrimination in food consumption within families continues to be a serious concern in trying to solve problems of maternal undernutrition. Quality of nutritional data that is collected is considered to be not of great quality, and hence makes it difficult to design evidence-based policy. Let us now look at the ICDS, or the Integrated Child Development Scheme. The ICDS program was initiated to address the persistent problem of child nutrition in India. It was initiated in 1975, which makes it one of the oldest social programs operating in the country, in 33 blocks, and used the BPL, or the below poverty line household criteria, to deliver its services. Following a Supreme Court order in 2004, ICDS was expanded to cover all states in the country. At present, the scheme covers more than 70 million, if not more, children and 15 million pregnant and lactating mothers. What the ICDS does? ICDS operates through grassroots health workers, the Anganwadi workers, AWCs, and their helpers, who provide 8 key services to children of the age group between 0 to 6-year-olds and their mothers. These include supplementary feeding, immunization, health checkups and referral in case of serious illnesses, and preschool education for 3 to 6-year-olds. The program has expanded into components that include adolescent girls' nutrition, health awareness and skill development, as well as income generation activities for women. The broad goals of the ICDS was to improve the nutritional and health status of children below the age group of 6 years and of pregnant and lactating mothers, to aid the psychological, physical and social development of the child, reduce the incidence of mortality, morbidity, malnutrition and school dropout, coordination of policy and implementation across ministries and departments, and health and nutrition education for mothers for looking after the nutrition and health need of the children. The last is considered to be one of the most important interventions in order to ensure that the supplements are properly utilized and in order to improve the nutrition status of the group in question. The coordination and funds for the ICDS, where does that come from? The program is coordinated by the Ministry of Women and Child Development. In fact, a large proportion of the budget of the Ministry of Women and Child Development is spent on the implementation of the ICDS program. The ministry works with the state governments to evaluate and monitor the performance of the scheme. Since 1992, with the passing of the 73rd Amendment, Panchayats have had active in implementing and monitoring the scheme. ICDS is funded by the center and the state. The program has multi-sectoral approach to child well-being. It incorporates health education and nutrition intervention. The ICDS stipulates that there must be one Anganwadi center per 1,000 population and one per 700 people in tribal areas. The Anganwadi workers and the Anganwadi staff are supervised by the Child Development Project Officers at the block level. The Child Development Project Officers are in turn supervised by District Program Officers. Some criticisms of the ICDS that have grown over time. Top-down program with no community initiative or ownership. This is supposed to be one of the reasons why the ICDS benefits are not as well embedded in community structures as they should have been, which would have led to better outcomes. Not very efficient or equitable, low coverage in poorer states, service delivery not sufficiently focused on the youngest group of children, leakages and irregular supply of food, poor infrastructure including absence of toilets in Anganwadi centers, shortage of staff, inadequate supply of educational material and vaccine, which means that the other components of the ICDS, apart from the feeding programs, are not successfully implemented in many states. Some concerns are the greater emphasis on food security but not enough attention to other interventions that can improve child nutritional outcomes. These are listed as improving child care behavior, including breastfeeding, weaning and diets, household food budgeting, disease prevention and control, micronutrient supplementation, child growth monitoring, supplementary poor performance of supplemental nutrition, deworming, iron and micronutrient supplementation, part of the program need considerable strengthening for it to truly fulfill its broader goals. Determinants of malnutrition are multidimensional. However, too much emphasis on ICDS is given at present on food security. Not enough attention is given to other interventions. These other or non-food interventions may include improving child care behavior and micronutrient supplementation, disease care and control. We now move on to the other nutrition program, which is a school feeding program or the midday meal. The midday meal scheme is the world's largest school feeding program. It is operational in all states of the country, and it reaches about 120 million children in 1.2 million schools. The scheme originated in the school feeding programs initiated by some states such as Gujarat, Kerala, Tamil Nadu and Pondicherry in the 1980s. In 1995, the National Program of Nutritional Support to Primary Education was launched as a centrally sponsored scheme. It covered 2,408 blocks. In 2002, the coverage of midday meal was extended to all children studying in classes 1 to 5 in government and government-aided and local body schools, and also to children studying in EGS and AIE centers. Since 2007, the scheme has been revised to cover children studying in upper primary classes. Over time, new food norms have been introduced and increased allocation has been made for paying the salary of the cook, for transporting grain, for the cost of cooking fuel, and for the construction of demarcated cooking area within schools. Three arguments in favor of school feeding programs: equity, nutrition, and education. The equity aspect of school feeding programs is an interesting idea. It argues that eating meals together in the context of school enables children to break down age-old social hierarchies like caste structures, which previously prevented children from different caste communities to interact with each other and share meals together. Therefore, a school feeding program helps to break caste barriers by teaching children to sit together and have a common meal. The nutritional aspect, the using midday meals to enhance the nutrition of children who may not be obtaining enough balanced diet at homes or whose parents might be too poor to ensure that they get 3 square meals a day. Fostering higher school enrollment, better learning achievement and regular school attendance, which would contribute to better attention and better performance by students in school. Repeated revision since 2006 has been seen to be one of the major problems in the implementation of the midday meal program. Lack of clarity about the objectives, although stated objectives is the universalization of primary education. The absence of linkage with the Ministry of Health and Family Welfare, lack of evidence on impact whether midday meal has truly reduced chronic hunger or malnutrition among school-going children, and there has also been irregularities in drawing and utilization of food grains for the program. There has also been insufficient funds to cover cooking costs and delays in budget allocation. Quality of food served in different schools all over the country has been a huge cause of concern. There has been several incidents in which children have fallen sick or worse, and food served in different states have also diverged from the prescribed norms. Moreover, states often fail to provide micronutrient supplementation. Midday meals could also become a health hazard unless hygiene is maintained and quality of ingredients is ensured. However, many observers have also highlighted the multi-layered potential benefit from a program like midday meal if it is well implemented. And this includes issues such as the elimination of classroom hunger. The idea is hungry children are not very good students because hungry children cannot maintain attention in what is happening in classrooms. Healthy growth of school children who are perhaps not being able to obtain food at home. Raising children's intake of calories and protein by supplementing the food that they do get at home. Providing children with key nutritional supplements such as iron and iodine, which may be deficient in their traditional diet. Opportunities for initiating mass deworming programs, and which would lead to better health and less spread of infections among children. Apart from nutritional benefits, the midday meal program can also contribute to greater social equity by encouraging children from different caste groups to eat together. It also aimed at ending gender disparities in consumption, because in schools, food allocation is often at the household level. Food allocation may discriminate against children based on gender, but that is not something that would happen in a classroom. a form of economic support to poorer families who can therefore use their meager incomes for other purposes. Some observed impacts: enhancing school participation for underprivileged children and girl children. Empirical research in Rajasthan found sharp increase in enrollment rate in underprivileged localities soon after the introduction of midday meals. There is also a growing evidence that the program increases school attendance amongst the younger group of children who would otherwise stay out of school. It reduces the cost of schooling. In some states, provides employment for women from underprivileged sections who can be engaged in cooking the meals or serving the meals. In some states like Tamil Nadu, the MDM has worked well for 20 years, while in other states like Bihar and Uttar Pradesh, it has a very poor performance despite Supreme Court's activism on this account. State budgetary allocation differs from state to state and affects the implementation of the program. Under the National Food Security Act, which we discussed in our module on food security, school feeding programs are now legal and justiciable, which essentially means that it's part of the right to food, and therefore all government schools have to implement the midday meal school programs in order to not violate the conditions laid out in the Right to Food Act. If we look at the Integrated Child Development Scheme and the midday meal program, these two are supplement the other interventions that the government may be doing in the context of, say, guaranteeing poor people's income, raising their income, making farmers' livelihoods more secure, and other social safety and poverty reduction issues. The difference between nutritional interventions and these other forms of social programs essentially is these are very closely targeted, both in terms of the objective that it is trying to achieve and also in terms of the group that it is addressing. Social welfare programs like nutrition programs aim to address observable deficits in health and well-being in society. In the context of India, these observable deficits for a really long time has been poorer attainments in food security and nutrition among certain population groups, and especially certain age groups, and also amongst women. Therefore, the ICDS and the MDM can be seen as an aspect of health policy. They can also be seen as an aspect of food security. They can also be seen as complementing poverty reduction interventions. And overall, what it does is it addresses and reduces the risks that poorer communities may experience in leading their lives and in their ability to attain well-being. With this, we come to an end on the module on nutrition schemes under social welfare programs in India. To summarize, what have we learned in this module? We have tried to understand the state of nutrition in the country. We have looked at the data that is provided by the 2 rounds of National Family Health Survey. We have found that the overall situation of undernourishment in the country is improving, while there is still a lot of work that needs to be done. We looked at 2 very large and very old social welfare schemes that India has been implementing for a very long time. And what we find that to a great extent, despite its many shortcomings, these programs, in addition to other interventions, have been able to bring about substantial improvement in the nutrition status of children and women in the country. Thank you.